Thank you very much for that kind introduction, and good afternoon to all of you here. So the topic I've got is an endocrine perspective to sexual dysfunction in males and females. I would like to slightly tilt the balance so that this is predominantly a male sexual dysfunction in endocrinology topic, and I will touch upon a few aspects of female hormonal sexual dysfunction as well. So I would like to quickly start off with a case. So I will be presenting two short cases, and then I would like you to just bear this in mind towards the end of the talk, hopefully if we have time to look at what happened. So this is a 26-year-old asylum seeker who just had his application for asylum failed a week prior, and he presents to a busy London A&E hospital on Christmas Eve, as they typically do. He presents with complete loss of vision and extreme fatigue, nausea, and vomiting for 2 days, blood pressure of 70/40, very low sodium, and an extremely low cortisol, and prolactin, which is nearly 1,000 times the upper limit of normal, and his testosterone levels are very low. And his MRI scan shows a 4-centimeter tumor in the pituitary with some internal hemorrhage. Once he was stabilized, he had further history taken, which showed that he had no libido for the last 5 years, but he had put it down to the stress of migration. The second case is something that we are all familiar with. We see it on a day-to-day basis in our clinics. This is a 54-year-old gentleman with a BMI of 45, diagnosed with type 2 diabetes, severe sleep apnea on CPAP, hypertension, hyperlipidemia, extreme fatigue and poor sleep, erectile dysfunction. And his investigations show a low testosterone, 7.2 millimoles, which is just below 200 nanograms per deciliter, and that was confirmed on repeat testing. And his sex hormone binding globulin is on the low side, and his FSH and LH are in the normal range. Okay, so when we talk about sexual dysfunction in endocrinology, what's an endocrinologist's role? Why is an endocrinologist even in this conference? You might be wondering. And so your two significant hormones related to sexual response are estrogen and testosterone. Now, it's always been a subject of debate over the decades as to whether these hormones act individually or synergistically and mediate the same actions in men and women. But for the purpose of this talk, I am just going to focus mainly on androgen deficiency in men. We will hopefully touch on some other endocrine disorders if we have time. And I will also focus on diabetes and obesity in men. I will also try and show a few slides on estrogen deficiency in women. Now, when we look at the clinical features of sexual dysfunction in relation to endocrinology in men, the predominant features are low desire, impaired arousal, and lack of spontaneous erections, in addition to erectile dysfunction. You may also get other clinical features depending on the etiology. And when we look at women, we have heard from many other speakers, some of the excellent speakers, and as Lisa mentioned, there is low desire, impaired arousal, dryness of vagina, painful sexual intercourse. And one of the key differentiating factors here is that there is disruption of normal menstrual cycle, which we will come to in the next slide. If we look at sexual dysfunction, generally women tend to present earlier than men in the life history. And this is because of the menstrual disturbances. But why should an endocrinologist bother about this? If you have an endocrine cause of sexual dysfunction, there is very good evidence. For example, if you look at erectile dysfunction, there are plenty of randomized controlled trials, and there are systematic reviews of randomized controlled trials which show that treatment of erectile dysfunction improves self-esteem, stabilizes low mood, and improves symptoms of depression. Also, equally importantly, the diagnosis of endocrine sexual dysfunction may help to uncover underlying serious illness, for example, significant pituitary and cellular tumors and adrenal insufficiency. And also, erectile dysfunction is a marker of cardiovascular disease. Now, if you look at erectile dysfunction in diabetes, even in the 10th century, this is a Middle Eastern philosopher and physician, Avicenna, who had described collapse of sexual function as a complication in diabetes in men. And it took nearly several centuries, and it was not until the 1950s that these were systematically studied. And this is from a major district general hospital in the UK, where you can see that erectile dysfunction increases in incidence in people with diabetes. And once you hit 50 years of age, your incidence of erectile dysfunction is as high as 50%, to the extent that you can pretty confidently say that erectile dysfunction is the commonest clinically apparent complication in diabetes in men. If I just go through the mechanism of erectile dysfunction in men, the main mediator is nitric oxide, and nitric oxide is produced in the endothelial cells as well as in the parasympathetic nerves. And this helps with the mediation of smooth muscle relaxation and aids in erection. Now, when you have endothelial dysfunction and autonomic neuropathy, the combination results in impaired production of nitric oxide, resulting in erectile dysfunction. It is not surprising that erectile dysfunction and cardiovascular disease share plenty of common risk factors, including hypertension. Most people tend to smoke, and you may be on other medications which you use for treating comorbidities, which may also be associated with erectile dysfunction. And as with any chronic disease, you have an overlay of depression and other psychological and personal issues, which tends to compound the problem. If you look at major studies in type 2 diabetes, large randomized controlled trials, one of the largest was the ADVANCE trial, which looked at glucose control and microvascular complications. There was a subset of 3,000 men who were studied, and they managed to do baseline erectile dysfunction surveys at the outset of the trial and 2 years later. And you can see that those who had erectile dysfunction at the outset and when it persisted, there is at least a 50% increase in the risk of cardiovascular disease. And pretty much you see the same pattern when you look at obesity, even in the absence of type 2 diabetes. So obesity is pretty much due to visceral adiposity and the inflammation as a result of the visceral adipocytes. And this causes endothelial dysfunction. So it is not surprising that when your visceral adiposity increases, as you can see in this observational data from Enhanced database, that when your metabolic disease parameters go up, your likelihood of having erectile dysfunction also goes up. How do we manage erectile dysfunction? I don't want to go into too much of details, but pretty much you're treating the symptoms And the first-line therapy is phosphodiesterase inhibitors, which work on the cyclic GMP pathway to help with smooth muscle dilatation. And if you find symptoms suggestive of hypogonadism, you check for that and treat hypogonadism. And then there are other urological treatment modalities that can also be offered. This is also a very important opportunity to address their cardiovascular risk factors, including smoking, statins, addressing their glucose control, importantly, maximizing on the insulin sensitizer therapy. Now, if you look at the previous advanced trial, where you had that 50% increase in cardiovascular disease, this was done in the pre-GLP-1 and the newer insulin sensitizing therapy era. And hopefully, you can see a reduction in the cardiovascular disease with all these agents treating type 2 diabetes and obesity. Which takes us on nicely to hypogonadism, which by definition in men is reduction in the levels of androgens, mainly testosterone, which presents with low libido, predominantly erectile dysfunction, and other symptoms. Now, at this juncture, it's important to actually try and see if we can differentiate between organic and functional hypogonadism in men. Organic hypogonadism is where you have a very clear-cut low testosterone level. In addition to it, clear pathophysiology in the hypothalamo-pituitary gonadal pathway that is identifiable. And you have very clear clinical features as shown in the picture, and treatment with testosterone is clearly of benefit in the long run, and these patients do not generally tend to recover from the hypogonadism. Whereas in functional gonadism, hypogonadism, it is potentially reversible, and these patients tend to have milder clinical features, or sometimes none at all, but they do have, usually tend to have features of metabolic syndrome, including pseudogynecomastia and central adiposity, but they tend to have normal bone mineral density and normal testicular volume. And in these set of patients, you're more likely to benefit from lifestyle measures and weight loss interventions, and testosterone may be of some benefit in a select group of patients. So how do you investigate these patients? Obviously, as with anything in medicine, you rely on your clinical probability score by doing a good history and examination. And the best differentiators in terms of clinical features are low libido, erectile dysfunction, and reduced spontaneous erections. And isolated fatigue, low mood, reduced muscle strength, low muscle mass, and increased body fat on its own tend to have a low clinical probability. And you also need to take into account other features that may be present, like low bone density and low trauma factors, infertility, low sperm count, which usually go hand in hand with male hypogonadism. And once you've addressed the clinical probability, then you make a decision on whether you need to check their testosterone or not. And if you make a decision, you need to do an early morning fasting testosterone. And if your total testosterone is more than 12 millimoles per liter or 400 nanograms per deciliter, then you can pretty much rule out hypogonadism. But if it is below that, it is unlikely, but you don't start treatment straight away. You need to repeat the test, because most of the time when you repeat the test, especially if your clinical probability is low, you will find that the testosterone will come back as normal. If in doubt, and if you think they may have any conditions which alter their sex hormone binding globulin, then you would also check the SHBG and try and calculate their free testosterone. And once you have confirmed the diagnosis, you then make a decision on whether they have got primary or secondary hypogonadism. The treatment is obviously with testosterone supplementation, either in the form of injections or gels, and you monitor the hematocrit, PSA, and testosterone levels at regular intervals. Main contraindication is metastatic prostate cancer and breast cancer, and hematocrit above 50. You also need to use it very cautiously if men are seeking fertility. There are recent trials which actually show that there is cardiovascular safety, at least in the intermediate term, in middle-aged and elderly men who clearly have hypogonadism. Now, just briefly mentioning hypogonadism in women, the diagnostic pathway, there hasn't been a consensus so far, and the UK Society for Endocrinology Consortium has tried to bring about a consensus to the diagnosis. And the clinical definition is 3 months of amenorrhea with relevant clinical features of hypoestrogenism, and if you consistently find an estradiol level of less than 200 picomoles per liter or less than 50, then you make a diagnosis of hypogonadism, and depending on your LH and FSH, you make a diagnosis of whether it's primary or secondary. You don't necessarily have to rule out other causes of hypogonadal features to actually entertain a diagnosis of hypogonadism in women. And briefly about hyperprolactinemia. In men, it is pretty much symptoms related to hypogonadism, and same in women. Women tend to present early because of menstrual irregularities. And the treatment is the treatment of the underlying cause, which usually restores sexual function. Now, coming back to the case number 2, sadly, this gentleman had increasing doses of insulin through the years. He was on an antihypertensive and statin. This is again talking about pre-GLP-1 and SGLT2 inhibitor and antagonist era. And he gained further weight and since the diagnosis of the ED, and died in bed within 5 years of his first presentation with erectile dysfunction. On a positive note, the first case, this gentleman was resuscitated. He was treated with IV hydrocortisone and fluids, and he was subsequently commenced on a dopamine receptor antagonist, cabergoline, 1 milligram twice weekly, and his vision was restored after a fortnight, and his tumor shrunk to half the size in 4 months, and it was well away from the optic chiasm. He eventually needed external beam radiotherapy because of poor compliance with the cabergoline, but he successfully appealed his asylum application on medical grounds. So on that positive note, I thank you very much.